Good afternoon, folks. This afternoon's D is cognitive reserve. Helps helps the brain tolerate age-related and Alzheimer's pathology. So people with higher reserve show later clinical decline despite similar brain changes. It's built across the life course: education, occupation, activity, and can be strengthened but not guaranteed prevention mechanisms. Cognitive reserve, or CR, is a functional concept. It reflects how the brain copes with damage by using alternative networks, more efficient processing, or flexible strategies. Brain reserve, structure capacity, and cognitive reserve processing strategies are complementary mechanisms that explain why pathology and symptoms can be disassociated. Evidence and impact. Epidemiology, higher education, complex occupations, bilingualism, and lifelong cognitive engagement are consistently associated with delayed onset of mild cognitive impairment and dementia. Even when neuropathology is comparable, neuroimaging and residual approaches. Studies using residual uh, variance methods show some people perform better than predicted from their brain scans, supporting the idea of CR, measurable resilience. How CR works at neural level: network efficiency and flexibility. People with higher CR recruits alternative brain networks or use existing networks more efficiently under challenging structural factors. Greater synaptic density, larger brain volume, or richer connectivity. Brain reserve provide a buffer against pathology. Practical ways to build or maintain CR. Key actions that have the strongest evidence: education and complex work, formal schooling, cognitively demanding careers, ongoing cognitive activity, learning new skills, reading, puzzles, language learning, social engagement, regular social interaction, and group activities, physical exercise and vascular health, aerobic exercise. Blood pressure and diabetes control, limits, trade offs, and clinical implications. Delay, not immunity. CR typically delays clinical symptoms Once decline begins, progression can be rapid because pathology is already advanced. Heredity. CR is multidimensional and measured by proxies. Individual outcomes vary by genetics, comorbidities, and lifetime exposure. Intervention evidence. Randomized trials of specific CR building programs show mixed but promising results. Large, long trials are still needed. Practical next steps for clinicians, caregivers, and individuals. Access lifestyle proxies, education, occupation, activities as part of risk profiling. Prescribe multimodal programs combining cognitive training, social engagement, exercise, and vascular risk control. Set realistic expectations. Emphasize resilience and quality of life rather than guaranteed prevention. Cognitive reserve. CR is the brain's capacity to sustain thinking, memory, and problem solving, even in the presence of age related or Alzheimer's pathology. People with higher CR often appear protected because symptoms emerge later, though CR does not confer immunity. Quick guide. Key considerations before reading. What matters most? Sustained education, cognitively complex work, rich social rich social networks, and lifelong cognitive and physical activity. Discussion points. Choose multimodal long-term habits, learning, social engagement, exercise rather than isolated brain training tasks. Clinical framing. CR shifts the threshold at which pathology becomes visible. Once symptoms appear, decline may accelerate because underlying disease is already advanced. Definition and conceptual model. Cognitive reserve is best understood as a dynamic functional capacity, the brain's ability to deploy alternative strategies, recognize networks, and maintain performance under stress. It explains why two people with similar levels of amyloid, tau, or vascular damage can function very differently in daily life. CR works alongside brain reserve, the more structural concept referring to synaptic density, dendritic balancing, and overall brain volume. Brain reserve provides the hardware. Buffer cognitive reserve provides the software. Flexibility. Together they form a dual layer resilience. System that shapes how aging and Alzheimer's unfold. Mechanisms how CR operates. Network efficiency and flexibility. Individuals with higher CR show more efficient activation patterns during demanding tasks and can shift to alternative networks when primarily pathways are compromised. This flexibility is one reason they maintain performance under conditions that overwhelm others. Structural buffering, greater cortical thickness, richer synaptic networks. And more robust white matter pathways allow the brain to absorb more pathology before function is affected. Residual variance evidence. In imaging studies, some people perform far better than predicted by their structural scans. This residual performance is one of the strongest Im- imp- impractical signatures of CR, revealing resilience that cannot be explained by autonomy alone. Evidence and impact. Epidemiology. Decades of population studies show that higher education, complex, complex occupations, bilingualism, and cognitively rich lectures, activities, and are associated with later onset of mild cognitive impairment and lower dementia incidence. Neuroimaging, functional MRI, consistently shows that people with higher CR recruit broader or more efficient networks during memory and executive function tasks. Structural imaging sometimes reveals greater volume or connectivity through the causal pathways remaining under active investigation. Clinical impact. CR does not reduce pathology. Instead, it raises the threshold at which pathology becomes symptomatic. This means two individuals with identical Alzheimer's burden may differ by years in when symptoms appear. How to build and maintain cognitive reserve. Practical actions. Lifelong learning. Formal education. Early in life matters, but so does late life learning. Languages, musical instruments, advanced crafts, or any skill that requires sustained practice and novelty. Complex works complex work and mentally demanding roles. Occupations or volunteer roles involving planning, analysis, multitasking, or leadership strengthen CR across decades. Social engagement, regular meaningful interaction, clubs, community groups, shared projects support both cognitive and emotional resilience. Physical exercise and vascular health, aerobic activity, strength training, and aggressive management of hypertension, diabetes, and cholesterol protect the neural systems that CR relies on. Cognitive novelty, activities that challenge the brain, strategy games, cognitive creative writing, learning new technologies, promote adaptive network use. Limits, trade offs, and clinical implications. Delay, not prevention. CR postpones symptoms that CR postpones symptoms but does not halt disease. When decline begins, it may progress. More quickly because pathology has been accumulating silently. Measurement challenges. CR is inferred from proxies like education and occupation. Researcher, Researchers are working to identify direct neural markers of reserve. Innovation, intervention evidence. Trials of cognitive training programs show mixed results. When used alone, the strongest benefit comes from multimodal approaches that combine cognitive, social, and physical activity with vascular risk control. Equity considerations, access to education, occupational opportunities, and social resources shapes CR across the lifespan, making it both biological and a social construct. Okay, guys, that is your D for tonight. I will try and jump back on later for more shows. For now, Gator Wellness, take care, folks.